Welcome to Indian Society of Toxicology. Today we will be discussing about a toxicologic emergency which came to our ER. A 24-year-old female was brought to our ER with alleged history of deliberate self-harm by taking 13 tablets of venlafaxine, which is an SNRI, 150 mg extended release tablet, 30 minutes back. Initial 10-second assessment, patient was conscious, oriented and obeying commands, and she is able to answer in one full sentence with normal voice. Primary survey, her airway was patent, there was no pooling of secretions, hoarseness or gurgling. Breathing, her respiratory rate was 19 per minute and saturation was 100% in room air, and air entry was bilaterally equal. There was no added sounds or chest exertions were normal. Circulation, her heart rate was 90 per minute, blood pressure was 120/60 and all peripheral pulses were felt equally and bilaterally. Disability, her GCS was E4, V5, M6 with pupils 2.5 mm equally reactive. She was moving all four limbs and there was no rigidity. Exposure, her
temp... Why you are specifically telling rigidity?
Since it is a case of SNRI overdose, toxic manifestations of serotonin syndrome can come at any time. So that time there can be rigidity. In serotonin syndrome there will be rigidity, and if it is an NMS and all, there will be lead type or cogwheel type of rigidity can be.
What is the difference between rigidity of this type of diseases and rigidity what you see in Parkinson's? How do it differ?
Onset time will be there.
Okay.
Then there can be associated hyperthermia will be there.
Okay, hyperthermia and elevated muscle enzyme with the rigidity goes in favor of all these things. Whereas in Parkinsonism, only rigidity will be there. Other features of like fever or muscle enzyme elevation may not be there.
Can we just airway, what all problem you anticipate in airway in this patient?
Sir, in airway we have to check whether airway is patent. There can be pooling of secretions. In neuroleptic malignant syndrome and all, there can be increased secretions can be there. That should be anticipated. Or if at all the patient is taking some sedatives or some sedative overdose and all, that time airway can be compromised, sir. Similarly in breathing also, respiratory rate, the patient can have bradypnea if the patient has taken some sedative. Patient can have tachypnea in cases of NMS serotonin syndrome and all, tachypnea can be there, and in malignant hypothermia also.
Any
tachypnea.
Infections can present like this NMS?
Yes, sir. And infections can also be there. This encephalitis can be there. Tetanus, malaria.
Tetanus is the most important. How do you differentiate tetanus from NMS in clinical
Sensorium.
Sensorium is
intact in tetanus.
That is very, very important. Tetanus patient is fully conscious, whereas in NMS and all, there is altered behavior.
Again, bradypnea can be a post-ictal phase also. So there's maybe outside after consumption she had a seizure and she has been brought in, maybe post-ictal also, not due to the drugs also. So that factor also you can consider. So coming to circulation.
Circulation wise, the heart rate, this person's heart rate was normal. Heart rate can be increased in serotonin syndrome and all, tachycardia can be there. Then blood pressure also can increase in serotonin overdose. What is happening is this SSRI is that is selective serotonin reuptake inhibitor, but this venlafaxine is SNRI, so serotonin and norepinephrine reuptake will be inhibited. So the patient can have hypertension, so BP can be high.
And also hypotension if there is cardiotoxicity.
Yes.
There is refractory hypotension also can be there. The one thing is that such a patient once comes into the emergency room, the standard precautions what we do is for all the patients is start them on oxygen if needed and put them on cardiac monitor. That is very important here. Putting on them on a cardiac monitor and monitoring and getting an ECG as early as possible.
This patient, then other thing we have to look is autonomic instability also can be there in serotonin syndrome. So that can cause tachycardia, bradycardia, hypotension or hypertension can be there. Then sensorium also, sensorium either patient can be drowsy or irritable. Then pupils in serotonin syndrome, pupils will be dilated, mydriasis can be there. Then temperature also we have to check. Temperature more than 104 is hyperthermia. So these are
one clue from infections. Infections in normally you get 102, 100 like that, but in serotonin syndrome and all, it is very high temperature. That will give a clue that this is drug related fever.
So adjuncts to primary survey, in this patient airway and breathing was patent this time. So in circulation part we have attached cardiac monitors and we have taken an ECG. ECG was showing a normal sinus rhythm with a QTC of 413. It is normal range.
Can you?
Why QTC is important?
QTC is important because in all antipsychotic overdose, QTC can be prolonged, and prolongation means there is a high risk of arrhythmia. VT
What
can
arrhythmia?
be toxicity and VT.
Okay.
How does it cause cardiotoxicity?
Uh,
This SNRI or whichever antipsychotics or even anti-amitriptyline, how does it cause? Where does it act exactly?
at the sodium channels it will be acting, sir. Sodium channel inhibition action
So
will
sodium
be there.
channel, basically that is a mechanism of action. So it is just like any other antipsychotics. This thing also is very prone to develop for cardiotoxicity. So what all things you will look into the ECG? You said QTC.
ECG we
Before
have the
QTC, what else?
sinus tachycardia will be there, QTC prolongation will be there. Then in the AVR, when we are looking, the R wave will be more than 3 millimeter and the R by S ratio will be more than 0.7.
Okay.
These can be the
And before QTC, maybe the QRS also can start widening. So that is one of the earliest features. So tachycardia followed by QRS widening, maybe QTC prolongation. Then specifically look for the AVR. AVR. That is the most important finding. That is again one of the indication for to start for your treatment with soda bicarbonate.
This patient, 2 large bore IV cannulas were taken and blood samples were taken for total count, total CK, renal functions, liver functions, sodium, potassium and coagulation profiles.
Toxicology also.
Toxicology analysis of blood was taken, urine was also taken.
Pregnancy test.
This was also done. This should also be done, sir.
Should take consent and then send pregnancy test.
Baseline ABG was taken and there was no acid-base abnormality there. Then a patient was reassured and since the...
What acid-base abnormality you routinely get in this type of toxicity?
This toxicity unlikely, but lactic acid, post-ictally lactic acid, lactate can go high, or in case of sedatives and all, we have to look for PCO2 build-up.
Retention.
Then a patient was reassessed and since the time of injection was only 30 minutes back, Ryle's tube was inserted and we have taken gastric samples initially and we have done the gastric lavage. Ideally we should do the gastric lavage with red rubber catheter, but since that was not available, we did with the Ryle's tube.
Not with the red rubber catheter.
Sir, lavage tube.
Lavage tube.
It is not, previously it was red color. Now specialized tubes are available, but we are not using.
Gastric lavage catheters are available.
It is available.
Then activated charcoal was also given. 50 grams activated charcoal was also given.
What all conditions you specifically you need to do gastric lavage? Many books says it is not recommended nowadays. But which are the specific situations where you try to do? Because what they are telling is you take, it will be removed, it will be get emptied. So there is no point in aspirating. We are getting patients very late. But
ideally, if the patient is presenting within the first 1 hour, we have to do that.
One is that the exact indication is within 1 hour.
Then the patient's airway should be patent. Patient should be able to cope with the procedure, sir.
Okay.
Then we have to make sure that all the contraindications are not there. Like in case of corrosive injection, acid, alkali, or hydrocarbon.
Some condition like extended release tablets, they can still, you can even after that you can aspirate. A large quantity of poison when they are taken, the emptying may get delayed. Taken with alcohol, again emptying may delay. So even if textbook says less than 1 hour, sometimes we'll have to delay it. But we don't have a tube in our hospital because it's traumatic. That putting a tube is mostly traumatic in our setting. If we can treat with some other modalities, that will be better.
Then extend
again venlafaxine extended tablets.
Extend release. So we can think about multi-dose activated charcoal also. Okay. In this patient, so if we are giving that 50 grams activated charcoal should be given stat, and every 4th hourly 1 gram per kg should be given through Ryle's tube.
How do you give activated charcoal?
Activated charcoal will be coming as a powdered form. We should make it into a slurry by adding 250 ml of NS in that, and then we should give it through Ryle's tube. It is very irritant, so it should be given through Ryle's tube.
Okay.
Secondary survey, sir. There is no allergies. Patient is a known case of severe depression with psychotic symptoms and anxious and avoidant personality disorder. And patient is also having hypothyroidism. She is taking venlafaxine extended release tablet 75 milligram in the morning and 150 milligram at night, sir. So the ideal dose, maximum dose that can be given is 350 mg is the maximum dose that should be given a day, and more than 4 grams is toxic. This child took only 1.95 grams.
More than 4 gram is definitely cardiotoxic. The other things, it depends upon more than 1.5 and all. They can have seizures all other manifestations. To cause a cardiotoxicity and all, it should be more than 4 to 4.5 grams. That is more than 1.5 itself, they can have manifestations. Okay.
Then this girl is also taking olanzapine 5 milligram, then lithium 400 milligram at night, and Thyronome tablet she is on. And last meal was 6 hours back.
With this drugs co-ingestions, so whether there can be any possibility of a co-ingestion with other drugs also. So then what will be the scenario, what will be the presentation changes if you think about lithium associated lithium?
So lithium is having only a very narrow therapeutic range, sir. So therapeutic range is coming between 0.6 to 1.2 milliequivalents. So if the a person's lithium level is going more than 1.5, then the person might be manifesting lithium toxicity features.
Features like?
Initially it will be mild irritability, nausea, vomiting. Then there can be tremors, increased urination can be there. Then cardiotoxic features can be there. Then rigidity, these things can be there.
So what should be initiated at that point to remove lithium?
If it is the toxic, if we are getting the toxicology report fast, and if it is more than 4 milliequivalents, then that is a definitive indication for dialysis.
Okay. Olanzapine. What is olanzapine?
Olanzapine is a typical antipsychotic. So atypical antipsychotics are highly prone for neuroleptic malignant syndrome. Even the introduction of the tablet or the change in frequency of the tablets can cause neuroleptic malignant syndrome. So that also should be considered.
Thyroid and her present co-ingestion, any correlation?
Hypothyroidism can have depression, sir. So maybe she might be having associated depression.
That lithium can produce hypothyroidism. Both are possible.
There is a history of ingestion of 13 tablets of venlafaxine extended release 150 mg 30 minutes back, and after taking that, patient revealed that to the bystanders, and she itself told that there is no co-ingestion, and there was after that there was no vomiting, sweating, diarrhea, irritability, seizures, anxiety or drowsiness. And bystanders also had the empty strips with them, and we confirmed that she took 13 tablets. Systemic examination, head to foot examination, first her sad person score was analyzed in their higher mental function, that was 4.
Just tell what is sad person score.
Sad person score is basically looking in case of depressed persons, we will be checking the sad person score. It is a score total out of 14, and if the score is between 3 to 4, the person should be closely monitored, and if it is between 5 to 6, there is a high risk of suicide, and if it is 7 to 8, that person should be hospitalized. So sad person, as it can be used as a mnemonic. S for sex. So males are having high risk. If it is a male, we have to give a score of 1. If it is age is less than 19 and more than 45, we should give a score of 1. Then depression, already if it is a known case of depression, then we have to give a score of 2. Then previous attempt is P. So previous attempt, if it is there, we have to give a score of 1. Then excess alcohol intake is E. Then R is for rational or loss of thinking loss is there, that should be given a score of 2. Then S is separation or divorce, that also will get a score of 1. Then any C or O is organization. How was the attempt? If it was a very serious attempt, we have to give a score of 2. N means no social support, that will get a score of 1. And S is if the patient itself state that the patient will attempt again, that also will get a score of 2. So totally it is coming as 14. This person's it is only 4.
Okay. So less score means
tendency is less.
Okay, tendency less for suicide.
Then head to foot examination, we have checked for other hesitation cuts or any suicidal indentation marks. That was not there. Then musculoskeletal system examination was done, which was within normal limits, and she was moving all four limbs. And respiratory system and other systems were within normal limits. By the time her blood reports came, her total count was 10,000. We basically checked the total count because there can be leukocytosis in case of neuroleptic malignant syndrome. That was 10,000 only. Then her renal urea was 8.8 with a creat of 0.78, and electrolytes were within normal, sodium 142 and potassium of 3.2, and total CK was 520, and coagulation parameters were within normal limit. And toxicology sample was also sent. Toxicology samples were showing venlafaxine, and lithium was 0.26 only.
That's
that was
below the so within the therapeutic index.
Within the therapeutic index.
ECG?
ECG, we have kept her on continuous cardiac monitors, and it was she was always in a normal sinus rhythm. There was no tachycardia, and ECG QRS also was within normal limits.
What are the drugs got narrow therapeutic index in common practice?
Emergency room.
Lithium, warfarin, digoxin, warfarin.
We're not using much these days, but still very
Any other
common.
drug?
Bronchial asthma you can give.
Aminophilins.
Aminophilin now we are not using. Okay, it has got a narrow therapeutic index. Any anti-epileptic drugs? Phenytoin has got a narrow therapeutic index. So what is this narrow therapeutic index means what? There are so many drugs we are not discussing because we are not handling so many drugs.
Narrow therapeutic index means if the range is going more than that, there is high risk of toxicity.
Okay.
Comes as a formula, sir, wherein you have, it's a ratio basically, wherein you have like a lethal dose and a therapeutic range dose.
Correct.
So basically, in that the ratio will be too tiny or rather small. So so anything higher than the therapeutic dose
So
can
if it is
cause will be
if it is
lethal.
slightly higher than the that narrow therapeutic index, it will go to toxicity.
Toxicity.
If it is low,
It will be
slightly low, it's subtherapeutic. So it
Subtherapeutic.
is very difficult to keep in that
Range.
therapeutic
Particular
range.
range.
So you every time, if you want to properly treat a patient, every time you have to look for the levels. Okay.
Suppose the ECG is showing in, as we discussed, a prolonged QRS complex. So how will you defer the management now? What will be the treatment?
We have to treat with soda bicarb, sir. So the dose is 1 to 2 milliequivalents per kg should be given stat, and we can give it as an infusion. And every 4th hourly we will have to repeat that, sir. It is basically it is a part of enhanced elimination.
Enhanced elimination. Any role for the other agents? Any other antidote is specifically available for this?
Venlafaxine as
Nothing is available. Usually within 24 hours, the symptom onset, the drug will pass the first pass metabolism and it will be completely metabolized.
Usually peak levels will come within 6 hours, but since it is extended release, we have to monitor for at least 24 hours.
The ideal, what the recommendation is that maybe 16 hours, if they are able to monitor this patient, they can be safely sent back home. That was the recommendation. So, which is more potent in SNRI groups? We have venlafaxine and desvenlafaxine. So, venlafaxine, I think it is more potent to cause this problems, but desvenlafaxine is less potent to cause these issues. Okay, then what will we do when the patient develops hypotension?
Hypotension, basically, we have to treat with vasopressin is more ideal, sir, as compared to noradrenaline, because this SNRI is having norepinephrine reuptake, sir. So vasopressin is the ideal choice.
The routine fluid resuscitation should be done, and look for cardiotoxicity, and cardiotoxicity should be treated. And on top of that, if you want to tap in vasopressin, the agent of choice will be vasopressin. And any role for lipid emulsion?
Lipid emulsion.
Again, refractory hypotension, that is one of the recommendation. Refractory hypotension for the toxicological drugs, usually you can try a lipid emulsion. Okay.
How was the patient then?
Then the patient improved symptomatically, sir, and there was no tachycardia or anything developing. And we kept a psychiatric consultation for this patient, and they took over the case, and patient was shifted to the psychiatry.
Is it suicidal activities a police case?
When the we have to inform the police, but if the patient dies, then
So
that should
earlier
be
it was
an
considered to be a crime.
Police case.
Police case. Now it is not a
That is
police
not a
case.
police.
It's been
This one,
reformed.
if you are suspecting like impending death, you want to take a police has to get involved. Then you'll have to inform police. If the patient dies, then also you have to inform. Otherwise, somebody attempts for suicide is not a police case. We no need to inform police also. But impending death always, because we don't know what will happen, so better to involve police. But to make it a police case, that all depends on the person who is taking.
All the documentation, everything should make it perfect for a medical legal case. All the where the referral letters, what exactly they have taken, the timing of ingestion, all those things definitely we'll do, but we have to be more cautious in dealing with such cases.
Okay, thank you.